Hello everybody, I'm Dr. Nelson Bulmash. Many of you have asked me in the recent past, or longer, I've been derelict, my apologies, about putting some videos up of me doing my system, Torque Reset. So I'm going to do some examples here today, and this is Chelsea. Chelsea, how are you?
I'm good.
Wonderful.
Thanks.
Chelsea, what are you having trouble with? What would you like me to help you with?
Yeah, so I just noticed recently that my left big toe doesn't bend,
Okay.
and I have some ankle instability. My ankles pop a lot, so I didn't know
Got
if that
it.
was connected.
Yes. So you're having some trouble with your feet, probably your knee?
Yeah.
Yeah, okay, excellent. All right, Skylar, I'm going to work here. You come as close as you need here. So what I'm going to do first is I'm going to decide what I want to do. And the first thing I want to do is determine how effectively or ineffectively her toes, feet, ankles, and so forth are working. So she's complaining about a big toe. So we're going to put this here, and we're going to see how well it works or doesn't work. So flexion is not working well. Extension is okay, right? But this is a problem here. You having pain when I do that?
No pain.
Okay, now let's look at the rest of the foot. What do you notice here?
It's not moving.
It's not moving at all. Not at all. Okay, same here. Look at this. Cuboid, no movement here. All right, now I'm going to go here to the calcaneus, the heel bone, and we're going to see if we can get it to move. And what do you notice about your heel?
It's not moving.
Almost not at all.
Okay.
And so this is inversion, this is eversion. Can you see this adequately, Scott? So this is a problem. I'm going to guess you're definitely having some knee issues.
Yes.
Okay?
Yeah.
So let's start here at the ankle. And you notice that I can't even get her into a position of neutrality with regard to her ankle. I'm going to go here, and we're going to check a bone that really very few people pay much attention to, the unsung fibula. And we're going to start here distally, and we're going to push here on the anterior part of the fibula, and you have no motion. So your fibular head is not happy, right?
Okay.
So the lateral malleolus, not happy here. None of this is moving effectively, okay? Now, I want to show you something interesting. We're going to go straight up the fibula, no motion here. You start to get a little spring here. And this is good because I've had people come in who can barely walk, who the fibula is completely fixated,
Okay.
right? Top to bottom. Now, we're going to see now, right, and this is important, because what happens in a lot of people, particularly athletes, Chelsea, is that the fibula locks often in an anterior position. It means it does this, and it descends and moves forward, while the proximal fibular head can either remain in a neutral position, go forward, or in a posterior. Posterior is its most common fixation in my world. Okay?
Would that be more so because I have valgus knees?
Yes.
Okay.
Yes, exactly. Now, I want to show you something that's really important. Often when we check out knees, we'll check translation. And of course, this is forward translation, and this is negative translation. What do you notice as I do this? You have a nice spring.
Yeah.
What do you notice, Chelsea, when I do this?
Not much.
Not much. So she has a lot of faulty mechanics, right, of her lower extremity here. Now, I just want to compare, because there are people who are going to be watching this who are going to look at this and say, well, I don't know what normal is. Let's see if this is normal. What do you notice here?
It's a lot more.
A lot more motion. Now, this isn't great, but it's a whole lot better than the other side. Would you agree?
Yes.
Now we're checking the heel.
Okay. Better.
Considerably better. Now, let's check internal rotation and external rotation. This is one of those things that very few docs seem to check. So we're going to get here, tibial tuberosity here, the anchoring point of the quadriceps. We're going to come in here. This is internal rotation. This is external rotation. Any pain when I do that?
No.
It's really moving quite well. I'll make it move better, but it's working adequately.
Yeah.
Okay? Here's where it gets exciting. What do you notice when I do this?
Not a lot.
Almost no internal rotation. This is really important, guys. If you have a person with pain in their feet or faulty mechanics, feet, ankle, knees, hips, low back, you have to take care of this. If you don't, you're going to have a very difficult time getting a person's structure to work properly. Okay? So, once again, here's internal rotation, here's external rotation. Almost no internal rotation at all. Now we're going to check here, almost no external rotation. Now I want to share something with you. If you corrected all of this, she'd walk on and she'd be much better. But you think maybe we should check the hips? Yeah, here's why. Because often the poor knees get caught in the middle between a foot and an ankle problem and a hip problem. So I'm going to go up here like this. Chelsea, I'm going to lower you down here then, okay? Now, we're going to go straight up here, straight here from the patella. And by the way, you want to pay attention. Another part of the body that almost nobody ever talks about is your kneecap, your patella. And I'm going to show you why that's so important in a moment. So we're going to go straight up here. You got a nasty little point right here.
Yeah, that's tender.
Very tender. And that's very tender because your kneecap isn't tracking right? So we go up, not quite a hand. Sorry, got something on my hand there. And you have a trigger point right there, right?
Mm-hmm.
Not here.
Yeah.
So that's a sign that you probably have much better tracking of this kneecap than this one. Now I'm going to go up here, and here you go. Big trigger point right here.
Mm-hmm.
Okay? Now, watch this. We're going to come in here like this, and we're going to check for the spring of the hip joint. Very good. Could you feel that?
Mm-hmm.
Scott, I'm going to have you come right around me here, sir. Watch what happens here. Put my hand here, right on the head of the femur, and what do we notice? Nothing. This is very, very common. Chelsea, may I have you lie on your back?
Yes.
Now, I'm a big fan, in this case, of starting from the big toe and working upward. Scott, you might want to come right here for this, sir.
Mm-hmm.
Now, I'm going to grab just behind the base of the big toe here and listen very carefully. You can come even closer. So here's your big toe joint, metatarsophalangeal joint. Okay? Reset a dropped tarsal head. That's all I did. That's called crimping. That's part of my torque reset system. What do you think of this?
Wow, it's a lot better.
A friend of mine, one of my mentors many years ago, said to me, Nelson, God lives in the details. If I could ever get up and walk right now, she'll be astounded as to how much better she can walk. But we're going to make it work even better. I'm going to come in here and work on muscles of the arch. Another release, another release, another release. Now, all I've done is cleared up the musculature here in the arch and released the metatarsophalangeal joint. This is dramatically better, okay? Now, we're going to recheck. Look what happens to her heel. All I did was relax the tension of the arch and release the metatarsophalangeal joint, okay? Now what I'm going to do is I'm going to release the tension here. You ever seen that done before? Look at this. How does that feel, Chelsea?
Feels great.
Isn't that remarkable?
Yeah.
Now, I release that tension. Watch. Get right here. Look at this. Watch the movement of the calcaneus. Now, I want to show you a check that, once again, very few people do. Not many people adequately check for proper inversion, proper eversion, and hers is still stuck, by the way. It's much better, but it's still stuck. And they don't do a long axis extension pull of the calcaneus. The calcaneus has to be able to rock like this, right? So let's check this. Let's put it in a neutral point. You want to come right over here, Skylar? You'll probably see it even better. You will probably get it right here. Thank you so much. So I'm putting the ankle in a neutral position. Now I'm checking long axis extension. And Chelsea, what do you notice?
It's moving better.
It's moving better, but not adequately,
Right.
really, right?
Yeah.
And you have to put this in a neutral point. See, if I can go down here, it appears to be working fine. But let's put it in either a neutral point or get some extension of the ankle here. And now all of a sudden,
Okay.
and I want to show you, I want you to feel this difference side to side. Neutral point,
Mm-hmm. Okay, I can tell the difference.
Big difference. Now, let's check and make sure that the fibula, the distal fibula, is still fixated. You see how there's no motion here, guys? I want you to see this. Not much motion here at all. Here's this one. Here's this. Here's this. Can you get that? Watch this. I'm going to grab with this hand the heel. Calcaneus here. We're going to pull it into long axis extension, and we're going to take it into eversion. So we're not just going to pull it straight. We're going to pull it, and I'm going to take my right hand, and I'm going to do this to correct for the lack of proper eversion. We good? Everybody tracking? Mm-hmm. Now, not only am I going to do that, I'm going to take my thumb on the anterodistal head of the fibula here. Right, the malleolus, lateral malleolus, and I'm going to go down like this to reset it, to get rid of that anteriority fixation. I'm going to put these fingers here on the metatarsals to release them. This one specifically on the cuboid. Watch this. So we're going to go here, 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 here. 4-part move. Ready? Priming it, getting her accustomed to it, and releasing some of the tension, and here, boom. Now watch this. Now watch this. Now that moves normally. Now, she has so much tension here that I want to get rid of a little bit more tension. Got rid of some of it, not all of it. So now I'm going to focus right here on clearing metatarsals, and here we go. Now, look at the way my fingers are. I'm doing all of them concurrently, not one row at a time. That's just, after years and years and thousands of these, I can do that. Now, look at this. Here's a cuboid. Look at this arch. Look at this.
It's like Jello.
Now, would you humor me? And would you, actually, you know what? Let me, for sake of time, let me clear the knee and then the hip, and then I'll never walk. However, would you say you probably walk a lot better?
Yeah.
Okay, Chelsea, I'm going to help you up. Come right up here, turn around here. Skylar, I'm going to have you go, sir, on this side of me. We're going to release the popliteus muscle. I want you to get nice and close. What I'm going to do is I'm going to get on the upper part of the posterior aspect of the tibia. And I'm going to see how she's not moving, right? So we're going to get to the connecting points of the semitendinosus, semimembranosus, and popliteus in the back. My fingers are all applying pressure. You feel here and here. Mm-hmm. Now, really poor internal rotation. So what I'm going to do is I'm going to grab my contacts here. I'm going to release the popliteus first. You'll hear a pop, little one. Now I'm going to come here. I'm going to release this posterior fibula on this side, Skylar. You might want to lift it up for 1 second. You can see how there's no motion here? Mm-hmm. Right there, no spring. Now if I come here, Skylar, on this side, can you see that? Look at this.
Yeah.
Okay, watch this. I'm going to come in here. Feel that release?
Mm-hmm.
Look at this.
Wow.
Does that feel like you have more internal and external rotation?
Definitely.
Now I'm going to come down here as well. I'm going to clear out all these tight elements that border. You look at that. Woo!
So tight.
So I'm working all of these, the soleus, the gastroc, all along here so that we get rid of any of the adhesions or any of the tight muscle that borders the fibula. Now move that.
Wow. So much looser.
Isn't that amazing?
Yeah.
Now, I'm not going to get into a huge amount of detail on this next topic, but I want you to have a fundamental understanding. What happens is, as a person stands, as a person walks, you have force that goes through the body. What happens is, if you've got a dysfunction mechanically or neurologically, or both, eventually you end up with both, you get a waveform going through the body that creates fascial distortions, muscle distortions in a wave pattern. And I'm going to show you what I mean. Come right around here. This is quite interesting. So it leaves its telltale sign by going in a sinusoidal fashion through the tissue. And I'm going to show you how you can locate it. As I take my finger here and I glide, sticks. Here's one of the areas that's the muscle and the fascia are tightly adherent. Feel? Sticks, sticks, sticks. Gets longer, sticks. Watch this. This is my forearm. This is her thigh. I am not popping and creaking. She is. So we're going to find out how this force has spiraled through her thigh and created these muscular and fascial adhesions that if you don't break up, will cause her to go right back into the same distorted pattern that helped create this in the first place. So listen very carefully. Scott, you might want to come closer. We're going to start here and listen very carefully. Now, let's see if we can get this to release without a drop. I'm going to come in here. Skylar, I'm going to come right here. Can you see this okay?
Yeah.
Coming here, you just relax.
Okay.
Listen carefully. I reset her femur head. Now, would you indulge me?
Yes.
Walk for me.
That's much better.
Is there anything that is still bothering you in the lower extremity that feels like it's mechanically off?
Not on my left side.
Now I want to show you all something. Chelsea, lie on your back head right here. As I've gotten older, I haven't gotten lazier, but I enjoy using a drop table. It just makes life a lot easier. Now, I'm going to feel in here, and she still has the tightness in here. I have a drop table at my access. I'm going to drop it because I'm sure there's some fascia that's still locking in some areas of rotation or translation for femur head. And if I do this, you feel that's still a little tight?
Mm-hmm.
Watch this. Now, Chelsea, what do you think of this?
That's nice. It's really loose.
Okay. Now, it's still not quite as mobile as the other side. What do? What we do is we release her psoas and her iliacus muscles. Don't hate on me, Chelsea. I'm going to get right in here, and you're going to, Scott, come right here. You're going to, once again, you're going to hear the same popping in the same pattern. I'm going to get 8 releases. You're going to hear 8 separate releases here. I'm going to come in here, right above the pubic bone here, with my elbow. How did I know 8? Because I've done a lot of research on this. So what happens is the shorter the muscle, the tighter the bands of adhesion or aggregation. Chelsea? What do you think of that?
Yeah.
Now, while she's here, I'm a guy who likes to split hairs. I could let her go and she'd say, I feel much, much better. But let's delve a little deeper here. We're gonna go here. Stop me here. Ready? Hold. What do you notice here? This side's weak. Means there's pubic bone involvement. Is it okay if I reset your pubic bone?
Yes.
Okay. Now I can do this. No, not at all.
No? Okay.
I'm going to use a drop table. Why? Because it doesn't hurt at all.
Okay.
Doing this manually, you and I could be friends when I'm done.
Okay.
You might be a friend of mine. I know you did. Yeah, you might be my friend in a week or two when you see how much better you're working.
Yeah,
but
yeah.
when I used to do this without a table, I lost friends for a while.
Okay.
So we can muscle test this, and here's what I mean. Chelsea, I'm gonna put this right here, okay? Keep your elbow locked, hold. Strong arm?
Mm-hmm.
Yeah. Gonna get right here, inguinal ligament here. Now I'm gonna push up. What happens?
So weak.
Really weak. Now I'm gonna go down, hold. No change, still weak. What if I go straight down and hold? No change. What do? We check the other side. Okay? I'm going to palpate to cheat, and her pubic bone on this side has gone inferior. Watch this. So if we localize here and test, so we're going to make this side strong by creating a distortion on this side. Here's how we do that. Thank you, Chelsea. I'm going to come in here. Put your hands right here. I'm checking her weight. You don't need much force to correct this. You will lose friends if you do pubic bone adjustments hard. Why? Because most of us don't have a lot of padding down here, and Chelsea's one of those. So I'm going to get right here, half the distance from the anterior superior iliac spine, and the pubic bone right here. I'm going to come in like this, and we're going to drop it up at the, feel how it's stuck right there? Can you see this? Stuck right there. Moving fine here, there fine, here fine, not here. Boom. Bad?
No.
Not at all. Watch this. Now hold real hard.
Wow.
Now, folks, this is incredibly important. If you have somebody comes in who works like at a cash register for 8 hours a day, you'll change their life with this. Watch this. Let me help you. Spin. Now walk around.
New woman.
Now how does that feel? How does your whole body feel?
Yeah, it feels like I'm walking on clouds.
Right.
Yeah.
How does your spine feel?
My spine feels good too.
Now, we're going to pause right here. Skylar, you can